Hi, it's Amy. Welcome to Ask Dr. Amy. Today we're going to talk about reflux in babies. Like all my videos, this is for information and education purposes. It's not medical advice because I don't know your child's specific medical history. And these are not connected to any hospital or organization that I work for. All right, I'll start by saying that basically all babies have reflux. And we'll talk about why that is, why it's usually a benign thing that goes away with time, and what are some treatments or preventative measures that we can do. Reflux is when contents of the stomach slosh back up into the esophagus. This is a diagram of how the digestive system looks in an adult. It's also called the GI tract, which stands for gastrointestinal, so we'll use those words interchangeably. Our GI tract is supposed to be a one-way system. So the mouth swallows and then goes into the esophagus, which is this tube connecting the mouth and the stomach. And then the next station is we're in the stomach. Reflux has to do with the reverse of direction at this level. When the stomach content goes back up, it's called reflux. That's why the full name for reflux is gastroesophageal reflux, or GER. Now, when you add a D at the end of this, D stands for disease, that's when you have GERD, which is reflux that causes issues. But not all reflux is a disease. I'm going to make a little note for ourselves here in the corner. GER is just a straightforward description of the reverse direction, and it happens normally in most of us at some point, and it doesn't bother us. GERD, GERD, is the disease. Today we'll talk about both of these with respect to babies. Oh, and by the way, just to specify, the G in both of these means gastro, which means stomach, and the E stands for esophagus. So these words are just landmarks to tell you where we're talking about in the body. So both GER and GERD happen at the same place, but one is a problem and one is usually not. When we talk about reflux in babies, by far and away, it's the one that's not a problem, GER. The official number is that up to 50% of babies will have reflux, but in practice, that actual number is probably way higher, and that's because of anatomy. Let's first take a look at how the adult system works. The esophagus has two sphincters, which are rings of muscles that can open and close. The one at the beginning of the esophagus up here is called the upper esophageal sphincter, and the one on the bottom is called lower. The body is coordinated in amazing ways that work without us having to think about it. Let me zoom in here on the stomach to show you a little bit better. I only have room for the lower sphincter here, but just imagine the upper one is somewhere up there. When we swallow something, the reflex triggers the upper sphincter to open and let it go through. The lower sphincter then gets the signal to open. Oh, and by the way, the top sphincter will have closed again behind whatever we swallowed. And then the open lower sphincter lets the content into the stomach. And after that, it closes again, so the stuff in the stomach can't go back up even as the muscles churn the contents around and around. So to continue this one-way tract, everything then goes from the stomach into the intestines. It goes through the small intestine, large intestine, and you know how this journey ends, into the toilet. So in a perfect theoretical world, there should be no reflux. The food and water sit in our stomach with a closed lower sphincter and has nowhere to go but forward into the gut. But throughout the day, a lot of us can have some minor benign reflux, GER, and we never know because it doesn't really bother us. In 10 to 20% of adults, they can have GERD with a disease at the end, which can cause more persistent and bothersome symptoms such as pain, and sometimes with injury to the esophagus because the stomach content is very acidic, and that can irritate the inside lining of the esophagus. That's how we get heartburn, because the burning pain is around the same level as our heart. So really the functional difference between GER and GERD is a question of severity and what other complications it brings. In newborns, usually there's no real complication. Benign reflux is much more common, almost universal, and the reason is because their anatomy has a few crucial differences. All right, let's look at a baby's anatomy. Like a lot of other things in the body, the sphincter here is still immature and is still weak. That's normal, and the strength will get better with time, but for the time being, it's floppy and will allow the content to slosh back into the esophagus. Next, the esophagus itself is short because the baby is only so long, so the stomach is much closer to the mouth. Add to that a newborn's diet is completely liquid, so moves around very easily, and top it off with the fact that a newborn's stomach is the size of a cherry. That looks like an apple there, but it's a cherry, and that's not going to hold very much milk. Of course, the stomach gets progressively bigger as the baby grows, so that cherry size really only applies to the first few days. But still, in a small baby, it will never hold all that much. These are all the reasons why almost all babies spit up. It's mechanical. Most of the time, it doesn't really bother them. It's just a lot of extra laundry for you. Two important things to make sure here is that they still feed normally and they gain weight normally, and those two are tied together, of course. So on this growth curve, whatever percentile the baby starts on, we want to make sure the growth stays on track, following the shape of the curve. If they feed and grow well, then we call them happy spitters because it's benign reflux. Within the first 12 months of life, the number of babies with reflux peaks at around 4 months of life. And in the majority, it's gone by 12 months. Again, almost all babies do this because it's physiological and it's how the anatomy works at this age. And this is why pediatricians are so obsessed with a growth curve, because especially in the beginning, good weight gain tells us a lot. And in this case, with a baby that spits up a lot, seems to have a lot of reflux, we know it's benign GER, not a disease, if the weight tells us so. Now, premature babies are a slightly different case. They can have more bad symptoms or other associated symptoms with reflux. So if your baby was born before 36 weeks, the information in this video does not 100% apply. The anatomy part and the principles are the same, but the reflux can be more severe and it can cause more problems, such as with weight gain. They can have persistent respiratory problems, etc. So talk to your pediatrician about that. And not just in premature babies, but in all babies that have reflux that affects the weight gain, growth, or gives them recurrent respiratory infections. Then we're in the category of GERD, the disease. All right, let's look at what to do for GER versus GERD in babies. For normal physiologic reflux, there's no need for medical intervention. There's some preventative things that could help. Number one, positioning. The baby's mouth to stomach is basically like a floppy bottle. You know how they say you are what you eat? Well, the baby is a milk bottle with the milk sloshing around. So if the bottle's tipped over while it's still full, then the milk will come out. So keeping the baby upright after feeding is really just giving time for gravity to help the milk go forward into the gut and not go back up. If the baby is being watched by an adult, they can be put on an inclined surface or face down for a while, which could help with reflux. Being a pediatrician makes me really nervous about saying that, face down, but of course I'm talking about being watched, supervised time, and they should never be put to sleep like that, either on an inclined surface or face down. And by the way, for positioning, car seat is actually not a good place. It's misleading because technically it's sitting up, it's upright, but because the baby is scrunched up and hunched over, the position puts extra pressure on the stomach, which can increase spitting up. It's like squeezing the bottle from the bottom. Or the second thing to keep in mind is the portion size of the meals. Again, think of that cherry and the volume. I'm not going to tell you a specific volume here because I don't want us to be stressed out about the number of ounces. And we're all a little different, so there's no universal rule or how much the baby can eat at this day. But if you notice that your baby is spitting up a lot, try feeding smaller volumes with more frequency. And sometimes moms tell me the baby won't settle for the smaller volumes. They're still hungry afterwards. So maybe the appetite is bigger than the system can process at the moment. So in that case, maybe a break is needed in the middle of a feed. So they can still have the whole feed, but just slower in smaller volumes. It can be a bit of trial and error here to figure out the volume of frequency that works best and adjust that as the baby grows. Lastly, there's some evidence that there can be less reflux with breast milk compared to formula. Now, I support breastfeeding and using breast milk in general for a lot of reasons, but I also think that it's way more important to feed the baby than to continually stress and feel bad about it if breast milk is not an option. And sometimes it's just not an option. So by all means, try to use breast milk. But if that does not work, formula might lead to some increased spitting up, but as long as the kid grows, that's still benign reflux. And it's way more important to provide them with that adequate nutrition than to let them be malnourished by waiting only for breast milk. Now sometimes, however, spitting up is not happy, and that can happen with either formula or breast milk. We're going to shift gears here and talk about GERD, which is pathological, abnormal reflux. So some red flags here: lack of normal weight gain, like when the weight plateaus across like this on the chart, make us fall down percentile curves. Or if they're throwing up blood or have constant respiratory infections, they're not feeding well, or they're excessively irritable with every feed. As you can see, these symptoms are linked together. If they're not feeding well, then of course they won't gain weight well. Now, bad reflux is not the only thing that can cause these things, so the baby should be evaluated to rule out other things like infection, metabolic disorders, abnormal anatomy, so on and so forth. But if those things check out and it looks like bad reflux, your pediatrician might do a course of medicine to decrease the acidity of the stomach contents. Less acidic means less symptomatic and less pain, so a lot of times that can solve the problem and help the baby feed until he or she grows out of the reflux normally. Sometimes kids can have an allergy called milk protein allergy. In formula-fed kids, they can try special formulas with different protein structures to solve this. Or if they're breastfed, moms sometimes are advised to do an elimination diet to get rid of cow's milk and eggs in her own food, which could help with this allergy. This method would only work if the reason that the baby has GERD is because of the milk protein allergy. So if these initial treatments don't work, or the symptoms make us worry about other more serious things, then there are other possible workups. At this point, a GI gastrointestinal specialist is usually involved. And just to give you an example, one thing we can do is test the pH, which is a sign symbol for how acidic something is. We can test for that in the esophagus continuously over a period of time to see just how bad the reflux really is. We will want to rule out neuromuscular problems that change the way the muscles are coordinated in the throat for swallowing. And then we also want to make sure there are no anatomical abnormalities here. For example, some babies can have pyloric stenosis, but that's really not reflux, it's projectile vomiting of every single feed, every single time. And that distinction is important. There are also tests to make sure that the milk refluxed back up doesn't go down the wrong way into the lungs. And by the way, in a baby with normal anatomy, it's safe to sleep on the back, and the reflux here will not be aspirated or choked into the lungs because of the way the muscles are coordinated. So both the pediatricians and the GI specialists agree on this point. Don't let it keep you from sleeping on the back. If there's a serious problem with the sphincter tone of the lower esophageal sphincter, something that doesn't become stronger with time, as expected, then there are also surgical options for reflux, which can tighten this area here. But of course, surgeries are a big deal to consider, especially ones that change the anatomy, so other options are usually tried first. Now, from the mouth to the stomach, there are different levels where the problem could be. And with GERD, sometimes we just have to go looking for where the problem really is. Now, I just talked about all these possible scenarios for the sake of completeness, but if we're talking about probability, the vast majority of babies are happy spitters. So in most, the reflux is not going to be a problem and will go away with time. Thanks for stopping by today, and if you have any questions about this topic or want to see a video about a different question, please leave me a comment, let me know, and I'll see you next time.